Hello, my name is Natalie, and this is my PDSA Quality Change Project on catheter-associated bloodstream infections. This is for the class for Nursing 451, Nursing Leadership and Management. So a little bit about what PDSA stands for. It's Plan, Do, Act, and Study. It is a change management model. This is an often used process to help teams improve the quality of care. Improving quality is about making healthcare safe, more efficient, patient-centered, timely, effective, and equitable. First, a plan is containing objectives based on service needs are made. Do implements the plan. Study analyzes the results, and Act ensures the improvements are being implemented. So next is the issue identification. Compliance and education of infection control of catheter-associated bloodstream infections by using antimicrobial wipes and UV light to help clean high-touch surfaces, proper skin cleaning, port cleaning, and hand hygiene. So when I refer to catheters, I'm referring to peripheral IV lines, central lines, midlines, any sort of line that leads directly into the bloodstream. 1 of every 25 patients hospitalized in the United States will have a hospital-acquired infection. When patients come to the hospital, they're expecting to get better, not sicker. And by doing this, when they get hospital-acquired infections, they can lead to many more complications. So there are 28,000 deaths related to central line bloodstream infections each year. CLABSIs cost $3,700 and $29,000 in additional health care per patient and can add up to 7 additional days to a hospital stay, which is inconvenient because sometimes people just don't want to stay in a hospital. In 2009, the World Health Organization adopted new global guidelines for hand hygiene that included adheres to 5 critical moments for hand hygiene. So the 5 moments are before touching a patient, before a procedure, after the procedure, after touching the patient, and after touching their surroundings. And this chart is actually at the nursing station where we can wash our hands. So quality variance, unenforced prevention, education. So while 76% of the respondents reported adhering to the principles of hand hygiene, only 45.8% could correctly mention the steps in hand washing. So there's definitely a lack of education for use of for using the antimicrobial hand wash, as well as washing hands. There's also a lack of education for use of Cura's caps, wet times for antimicrobial wipes, hand hygiene, and proper skin cleansing. Also, I've seen nurses go into isolation rooms without using PPE at times. So there's definitely an undercompliance of personal protective equipment used when entering an isolation room. The root cause analysis. Nurses are not vigilant enough or aware of what they're touching before touching their patient, not wiping down vital machines before using it for the next patient, which I know I've seen a lot of nurses do, considering the unit is a 2-bed unit. So if they have both patients in the room, it's so easy to just go from one patient to the other. But however, we may not know what they may have because tests have not come back conclusive enough, and we may be infecting the next patient. Also, leaving ports uncapped. By leaving them uncapped, we're leaving them open to bacteria that just stick to the ports, and then once we stick like flushes in them and we flush, we're just leading it right into their bloodstream. And then there's nurses who are failing to adequately sanitize their hands. So on the sanitizing pumps, it says to use 2 pumps. However, a lot of nurses do use just 1, thinking it is sufficient enough. So who are the stakeholders? Definitely the nurses, because they have the power to cause or prevent a hospital-acquired infection. Medical insurance companies and patients play into this factor because when patients do acquire a hospital infection, they are more likely to have to stay in the hospital for antibiotics longer than predicted. And sometimes they may not be able to, the insurance companies can't pay for the length of stay, so a lot of the time patients may have to pay out of pocket, and this becomes very costly to them. And then lastly, of course, infection control department needs to be aware of these issues, just because they do have to consider the data and report the data back to centers of disease. And all this information is all accessible to employees and the public as well. So I was able to interview Ted Ellinger, who is our infection control RN. I just had him elaborate on the uses of different devices in our hospital, in this hospital, that can help us to prevent infection. So a couple things he mentioned were the bio patches that are used on the PICC lines, and they have CHG already built into them, so it helps prevent bacteria from entering the site. Also, we're using CHG lotion to help cleanse those with CHG lines, or if they have multi-drug resistant infection, central lines, and dwelling catheters and such. We're definitely still using our Oxivir TV wipes. However, we need to start paying more close attention to the wet times that are necessary for it. So the Oxivir wipes, it's 1 minute. Bleach wipes are 4. And then the newest one that we have is the Clorox UV room light, which is actually very interesting because the way it works is after the EVS department has come in and cleaned the room, there's always that human error of not being able to wipe down every single part of the room. So the UV light stays in the room. It helps to emit UV light. It kills the DNA of the bacteria, which in turn kills the bacteria itself. So it's pretty awesome. Then we also have secret shoppers, which are staff members who go around the units monitoring for hand hygiene and PPE compliance. This gives us a more realistic view of what's really going on the unit when the managers and eyes are not on people. Like, what do we do when people aren't watching us, basically? So the solution is to use proper skin prep, use the Curos caps. They're always hanging on the IV poles, and if there isn't, it does not take very long to go to the med room and hang up some more. Wiping down surfaces with the proper wet times, using Clorox UV and light, and that is more so for the EVS department to implement. And the #1 solution is hand hygiene. So hand washing using antimicrobial, antibacterial sanitizers, as well as complying and educating nurses in services. So we are accountable for each other, patients and nurses alike, to wash our hands and prevent infections. So hand hygiene for nurses and patients, because we need to be able to educate the public as well. It's everybody's job to prevent infection, and everyone can prevent it. Using those microbial and wipes to wipe down those high-touch surfaces. We're touching a lot of things a lot of the time. In fact, because a mode of transmission is via contaminated hands, hand hygiene is the single best method to prevent the spread of infection. Then we're using our EV lights, proper use of PPE. We need to stop thinking that it'll slow us down. It's actually there to protect us, not being lazy about it. And also adhering to our policy of central line dressing changes and how we clean those, and it's found in our hospital policies. So in the analysis of this hospital's central line associated bloodstream infections as well as MRSA blood infection, the observed number has gone down significantly. Well, it went from 1.48 to 1, and that may be small progress in a way, but it is progress in itself. So the next steps for this plan is basically would be for implementation and education. So when I first started at this hospital, I used to always see hand hygiene posters that were a little kind of like comical ways to get people to wash their hands, like this one saying like, what's on your hands, wash those germs away. And cute little posters like, ask me about infection prevention. It's just those little reminders that help nurses and patients know that they need to wash their hands and be more aware of that. We touch so much in a day that we don't quite understand what is on our hands and what we could be doing to people. So according to Haverstick, patients' suggestion to increase patient hand hygiene included the following: having staff encourage all patients to perform hand hygiene, giving each patient or his or her own sanitizer, recognizing that patients would be more apt to use hand sanitizer than hand wipes, having hand wipes at the bedside. So patients need to also be reminded, as well as nurses, we're human, we do forget sometimes, and we do need to be re-educated from time to time. That is human error in itself. But as long as we keep each other accountable, infection prevention can be minimized. And these are my references I used, and that concludes my presentation on catheter-associated bloodstream infections. Thank you.